So we've got Meredith Beaton. So Meredith is an assistant professor and APP clinical director in the division of hematology here in the Blood Disorders Center. So a little bit of background on Meredith. After working for several years as a middle school teacher and researcher, she returned to nursing school and graduated with her NP degree from Yale School of Nursing in 2016. She serves on a variety of committees within UCH and the University of Colorado, including the planning committees for this blood cancer boot camp and the APP Oncology Summit in Denver. She has presented at national conferences and been published in JADPro regarding her blood cancer expertise and lectures at the CU School of Nursing. When not working, she enjoys adventures with her 4 daughters. And of note, Meredith worked a night shift last night, and remarkably, she is awake and looking pretty alert today. So Meredith is going to talk to us today on physical exam, labs, and diagnostic testing for blood cancer patients. Please welcome Meredith Beaton.
Well, thank all of you for being here early this morning. I was a little bit worried when I walked in and there were only a couple of people sitting, and I was like, well, maybe this will actually be better that I didn't work last night. I don't know. I mean, that I did work last night, but so first off, pardon me if something that I say today does not make sense. Just know we're coming in on, 20-ish hours of no sleep. So bear with me, please. All right. Apologies in advance, but this is going to be great. We are all going to talk about physical exam, review of systems, and all the things, all the tools that are in our back pockets as heme providers. So here we go. This button, there we go. What are we going to talk about today? How to conduct a thorough physical exam and review of systems in a new heme malignancy patient, understanding diagnostic testing, and understanding how these tests affect our clinical practice. So, all right, I don't have anything to disclose. Okay. So this is, I think, the most important part of this entire lecture, right? Your patient is going to tell you everything. That's it. I'm done. No, I'm just kidding. Just kidding. No, so your patient, though, they're going to give you all the clues that you need to use the tools at your disposal to figure out what's going on with them. All right. So it's really important that we all listen to our patients. And I know we hear that and we say that, but every day that I am a practicing clinician, it is reinforced in my mind even more, right? They're giving us all the parts to put together. We just have to put them together in the right way. So the review of systems, this is like the most important toolbox that you have. And it feels, maybe sometimes like it's a little bit routine or mundane. I ask, I don't know, probably 50 questions in my review of systems. I do a thorough head to toe because a lot of patients will say, oh, I've got nothing. And you're like, okay, cool. Tell me more. Any headaches? And they'll say, oh, well, yeah, I mean, I have had a few headaches. Is that normal for you? Well, not really, but I just take some Tylenol and they go away. And you say, okay. Any shortness of breath? Well, no, I mean, when I get up and walk in from the parking garage to my office, I'm a little bit short of breath, but I'm not really short of breath. And you're like, okay, interesting. All of these things, right, that they are not considering to be symptoms, you start to put together in your head and you say, a little bit of headache, a little bit of shortness of breath. I wonder if maybe you're a little bit anemic, right? Some patients will say, oh yeah, well, I've lost some weight recently. And I'm like, okay, did you mean to do that? And they say, no, isn't that great? And I say, why? Is it because you're nauseous? Or is it because you're feeling really full? Those are 2 different reasons to be losing weight, right? Is it because you're having profuse diarrhea, right? All of those things are going to send me on a different path, right? And I might suddenly decide, ooh, if you're feeling full as soon as you've had a bite to eat, I might start thinking to myself, I need to do a really good abdominal exam and see if you have some splenomegaly going on, right? So starts to get me as a clinician thinking down certain paths as I talk to patients and their review of systems. Okay. Next up, the physical exam. I know, we talk about this one all the time as well, but this is really important that we do head to toe. The number of patients who I have who say to me, I have a rash. And I say, cool, can I see it? And they say, oh yes. And then I see some beautiful florid petechiae all over their lower extremities. And I say, that is an interesting rash. right? And then I am again down the path of like, your platelets must be very low. I wonder what's going on for you, right? So all of these pieces I put together, as I look inside their mouth, I say, it looks like maybe you have a little sore in there or your gums are a little bit swollen. And they'll say, oh yeah, that's been happening for a few months now. Okay. So you have some delayed wound healing. Your body's not able to fight off infection. Interesting. I wonder what your white blood cell count is, right? All of these things, again, putting those puzzle pieces together. Okay. And that brings us to the things we cannot see, right? Everything that lies below the surface, like our classic iceberg, right? So that physical exam, the review of systems, they get my spidey senses tingling about the things that I should be looking for when I do some testing. All right. We're all good with this. Yeah. We're all expert clinicians. We will know all the things before we even run a single CBC. We will know if the patient has acute leukemia, right? Great. Great. I still have like one head nod out there. So I feel like this is good. Okay. So blood cell formation, this is about what lies beneath the surface, right? Rather than teaching you an entire pathophys class, because we don't have time for that today, let's give a little Cliff's Notes version. Ready? Stick with me here. All hematopoietic stem cells differentiate into our two primary lines, right? We either have myeloid cells or we have lymphoid cells. Great, good so far. Those myeloid cells are then going to develop into our red blood cells, our platelets, and our white blood cells, those in particular ones that we love to talk about, the neutrophil that help us fight bacterial infections, okay? Our lymphoid cells, those guys also really important, right? Those eventually develop into all of our lymphocytes, right? Also help us fight off infections, different kinds, but those guys all work together to give us a wonderful, beautifully functioning immune system. And red blood cells and platelets, great. We release them into our bloodstream when we need them, except when they're not working quite correctly. And that's where we come in the field of heme malignancies, right? Blood cancers arise when something goes wrong in the system, okay? All of our cells contain some chromosomes, and if you remember, again, pathophys Cliff's Notes, chromosomes are those long strands of DNA that are comprised of genes, and those essentially take all of the coded instructions that we have to tell our cells what to do. And cancer starts when something goes wrong in that DNA. Great. Okay, perfect. Often there's some abnormal changes in the genes of your cancer cells, right? And those abnormal changes are called mutations, and those mutations are what determine where along the path your blood cancer arises. Okay, and they help us determine a patient's risk factors for developing certain kinds of cancer. For each of the blood cancers that we know of, there are genetic mutations that are associated with them, and they help also determine a patient's risk stratification once we get to that point. All right. So I love case studies. I hope you all do too. Case study number 1, Mr. D. He's a 63-year-old guy. He presented to the ED after returning from a trip to Ireland with his wife and a travel group. He has a 2-week history of a cough and sore throat that made swallowing difficult. Because of the pain, he reports that he's lost 15 pounds over the last month. He also endorses some swollen tonsils and some night sweats. Okay. This guy ended up being a little bit of a red herring for me. I won't lie, but I think he's a great case still. What is the first diagnostic test from Mr. D that you would want to see? It's the easiest one we have in our toolbox. Yes, thank you, Carrie. I would like a CBC too, right? So 2 weeks of cough and sore throat, weight loss of 15 pounds, like this must have been pretty darn painful. And pretty severe, right? Doesn't sound great to me. The night sweats are also concerning. Swollen tonsils, also concerning, right? Could be nothing. But since this is a heme malignancy talk, I'm guessing it's probably going to be something. Okay. So what kind of cancer does he have? Let's look at our smear on our blood. Here we go. So Mr. D comes back with this, and then the emergency department immediately calls our service and says, oh my goodness, you need to admit him. Why? what's on here that we're like, oh, I know what you have. High white count and blasts. Gold star, Carrie, thank you. All right, so acute leukemia. This is it. We don't need any more sort of tissue or confirmed diagnosis, right? We know you are not going to have a white count of 189,000 with 89% blasts, those very immature cells running around in your bloodstream, unless you have acute leukemia. If Mr. D had maybe had less of an anemia or less of a thrombocytopenia and a high white count and no blasts, then I could be thinking more of like a chronic picture, but unfortunately he doesn't. So he comes to our service, he has an acute leukemia. Some other things that I start to worry about and I want to get a little bit more testing of are what kind of acute leukemia, right? And for that, we start to think about getting our peripheral flow cytometry. So our flow cytometry is a lab test. It just uses like characteristics of some of those cells or particles of cells. And during that process, we take a sample of cells and we suspend them in this fluid and they get injected into this flow cytometer machine. It's very fancy in the lab and it looks at about 10,000 cells that can be analyzed and processed by the computer in less than 1 minute, which is great for us because it gives us a lot of information. These cells are then arranged in a single file line and they pass through a laser beam and it tells us, it categorizes them and it tells the pathologist what kinds of blast cells they are. Are they more myeloid, more lymphoid? And that gives us sort of the first branch, right? Are we looking more at an acute myeloid leukemia and acute lymphocytic leukemia? Doesn't tell us a lot about their genetic mutations, right? But it does give us that first step of information. This is really helpful for us as clinicians, because as we all know, testing can be expensive, right? And we don't want to necessarily send a bone marrow sample on any possible type of leukemia, right? That means that our pathologists, we send a lot of tests and we ask them to look at a lot of different things. We can narrow it down for them. It saves time, right? And saves some money in the process. And so those things are important for us to think about. So we can narrow down the test results for the all-important bone marrow biopsy. So whenever I talk to a patient up front, I can say, I'm kind of thinking that maybe it sounds like, based on your symptoms, based on what I see on this CBC, that you might have this kind of leukemia, but I don't have a crystal ball and I don't have X-ray vision. We have to do a bone marrow biopsy, right? That's the only way we know for certain. And so this is where we really get the information that we need to diagnose a patient and what kind of blood cancer they have. From that bone marrow biopsy, we collect 2 different samples, right? We collect our flow, which is the blood portion, the aspirate. Sorry, we collect the aspirate. Sorry, this is me, lack of sleep. We collect the aspirate from inside the bone marrow. That's the blood portion. And then we collect the bone marrow itself, right? So a little teeny tiny piece of the bone. And we send those all off to the lab for testing. One of the types of tests that we run is this immunohistochemistry. It's a special staining process that adds a chemical marker to all the cells, and then they're looked at by the pathologist under the microscope, and they can pretty quickly look at things under the microscope and say, oh yeah, look at this, and look at this, and I see this kind of special feature. And pathologists are just very smart. I don't know how they do it so quickly, but with those stains, they're able to identify pretty readily what might be going on. The other thing that we might send off is some more flow cytometry, just like we did on peripheral blood, but this time on the bone marrow. We can also do some genetic testing. So for changes that have developed over time, not necessarily genetic changes that are sort of in your, in like all of the body cells. These might just be in those cells in the bone marrow. They could also be in the rest of the body cells. That's kind of a different topic. So some of these changes happen at the gene level or the chromosome level, and cytogenetic tests help us look for those changes or abnormalities. Karyotype and FISH are 2 ways of doing that cytogenetic testing. Karyotype is that picture of the chromosomes. It's kind of the classic when we think about genes. What you're going to get back. And it really helps pathologists look for extra missing or abnormal pieces of chromosomes. You might have 3, you might have 1, you might have some parts that got flipped around somewhere. It helps them kind of get the bird's eye view of that chromosome analysis. And then FISH, or our fluorescence in situ hybridization, is a special method that involves some dyes and probes that attach to specific pieces of DNA. And that looks for very, very specific translocations or inversions of those genetic pieces that are too small to be seen with some of our other methods. These can't detect all of the known changes on a karyotype, but they can test for anything that we already know about or we think we might know about. So especially at initial diagnosis, we'll run a pretty big panel of FISH testing for an acute myeloid leukemia to test for all of the different types that we think they might have. And then once we know what your genetic mutations are, we can only test for those ones in the future. All right, and then we have our molecular testing, and this includes testing for genes or proteins. It identifies the presence or absence of specific mutations. Again, this PCR testing can get down to that very specific genetic level for mutations and helps us find kind of the needle in the haystack, if you will. So it can find one abnormal cell amongst more than 100,000 normal cells, which is pretty impressive. So this one can be very helpful when checking for very specific mutations, again, like the BCR-ABL mutation or a PML-RARA mutation. And it can also be helpful for checking in relapse in patients. All right, so what are some of the specific mutations that we worry about in our acute leukemias? In AML, I think for anyone that takes care of AML patients, we're pretty familiar with some of these genetic mutations. Your NPM1s, your IDHs, your RUNCs, your KITs, your TP53s, your FLT3s, there are others. There's a whole list of them in the NCCN guidelines, but these really help us identify also where our targeted therapies can be, which is really nice, right? A lot of these targeted therapies were not options for patients even just a few years ago, and they've given our patients even more possibility for getting into a remission and potentially getting to a cure, right? And so that's very cool. So, we think about a few of the ones that, are very, I don't want to say popular to use, maybe that's not quite the right word, but the ones we use a lot, right? Like midostaurin, gilteritinib for our FLT3s, we can use some of our IDH inhibitors, et cetera. So again, just more options for us as clinicians to provide potential for remission for our patients. All right, some of our ALL mutations. Again, we all know about the BCR-ABL mutation. That's an important one, but we can also look at other sort of translocations within our ALL patient population. And again, we have our targeted therapies. So these TKIs that we all know about are tyrosine kinase inhibitors that really specifically target this pH positivity or our BCR-ABL genetic mutation, which is that translocation 922. We have a lot of these that are available to us at this point that we can offer to patients as well. So some of our TKIs are also used in our other blood cancers, but primarily they were developed for our ALL patient population. All right, so that's leukemia in a nutshell. Perfect. Case study number 2. Let's move on to a different blood cancer, shall we? All right, Mr. L is a 36-year-old male. He presents to his PCP with a 3-month history of cough, intermittent fevers, severe night sweats. He has 2 young children at home who have been sick all winter, and he thought he was just catching colds from them. But this last cough and hoarse voice have lingered. Great. So again, because it's a lecture about blood cancer, I can tell you it's not just that he has a petri dish or a couple of petri dishes walking around his house, right? Spreading all their germs. He, in fact, probably has something, again, lying beneath the surface. What's the first thing that I want to do with this guy? If you have a cough for 3 months, what do you hope your PCP might order for you? A chest x-ray. I saw your mouth move in the back. I saw it. I'm a good lip reader. Chest x-ray. Yes. I would hope that my PCP would order that for me too. After I get my chest x-ray that shows this, a large mediastinal mass, then what do I think I might want to have? Yes, a CBC. Also, yes, right? a CBC, because everyone's going to, again, the ED will call and they will say, hey, we think this person has probably ALL or lymphoma, or a radiologist will write down concerning for lymphoma, which is always my favorite. But we'll grab a quick CBC, right? Because we don't know yet, right? You can have a large mediastinal mass with a leukemia, or you can have a large mediastinal mass with a lymphoma, right? So I'll grab my quick CBC. Great. It looks pretty good, which gets me thinking, he probably has lymphoma. Don't know. Why don't I know yet? Because tissue is the name of the game when it comes to lymphoma. You do not have lymphoma until you have a biopsy-proven lymphoma, no matter what you read on the chest x-ray. So a couple of other lab tests that could give us clues, right? Again, just clues as we're trying to build up our understanding of what might be happening for this gentleman. An LDH, we would expect that to be pretty high if he has a new lymphoma. Our beta-2 microglobulin also should be pretty high. And if he has B symptoms, now he's probably going to tell you, oh, I'm sick. I've been sick because of my kids. But you'll ask him and you'll say, well, have you always had these fevers? Do you know if you have fevers? Do you find yourself waking up in the night with night sweats? You know, have you lost weight? Right? You can ask about those B symptoms, and those will also give you clues. You might want to get some imaging. A PET scan is very important when we are concerned about potential for lymphoma, especially if we can't feel lymph nodes. A PET scan is our positron emission tomography. It's this imaging that we can do where we basically place a special radio tracer onto molecules, and they get like labeled with these radioactive material. And we, the way that it works is because these radioactive tracers get picked up by, it's very similar to glucose. And we know that cancer cells like to divide really rapidly. They use a lot of sugar, so they pick it up and they hold on to it just like they would a glucose molecule. So you can see them on the imaging very, very easily. So this gives us a good sense of where those swollen lymph nodes might be. And then we can get a tissue biopsy. So this is, again, very important. We work with a lot of different colleagues in our field, but once we identify some good lymph nodes that hopefully are close to the surface, we can get some biopsies either with IR or with our surgical team, or really whoever will do that for us. Sometimes we need a bone marrow biopsy as well for patients, not always. But this can really get us down to the sort of fine details of what kind of lymphoma this patient might have. So there are just a handful of different B-cell lymphomas that this patient could potentially have. The reason I say B-cell lymphoma is because, number one, he has B symptoms, but number two, more than 90% of our lymphomas are B-cell lymphomas. So it's pretty likely that your patient will have that if they present with a lymphoma. These B-cell non-Hodgkin's lymphomas encompass a whole group of lymphoid cancers. Those are sort of the big branch over here. Versus your Hodgkin's lymphoma. There are over 40 distinct types of those. So again, this is where it's really important that we get that tissue biopsy to know what kind it is we're dealing with. Because what kind it is we're dealing with is going to change how we're going to treat it. So it's very important that we know that information. So again, there are a lot of different subtypes, as you just saw on the previous slide. And the reason for that is because they'll happen at different spaces within our sort of germinal center. And so depending on where in the path those mutations happen will determine what kind of lymphoma you have. And again, that will determine how we will treat that lymphoma. So very important information for us to have. I find that one of the pieces that gets really challenging, at least for us working, especially on the inpatient unit, is other services will say, oh, please take this patient, you need to start emergent chemo. And we'll say, there are so many different kinds. We can't start emergent chemo until we know what it is that they have going on. So this is where it's really important for us to kind of figure those pieces out. And again, depending on where in this maturation process our lymphoma starts to happen, it gives us the ability to have certain targeted therapies, right? So for example, we can use a BCL2 inhibitor like venetoclax for some of our follicular lymphomas. We can use venetoclax in some of our CLL patients who often have really high level of BCL2 expression. So, you know, again, opens up options for us in terms of treatment for patients. All right, case study number 3. big hint here. We talked about leukemia. We talked about lymphoma. There's one more big class of blood cancers we deal with. So case study number 3, Mr. M presents to the ED with complaints of back and rib pain, drowsiness, confusion, and constipation. He also recently started falling at home and now has a fracture of his right humerus. What else might you want to know about Mr. M? I love it. I love it. Can we start just like one step backward and just grab some quick labs? Is that okay? Great, great. Labs and some x-rays. I love it. So these are his labs. You'll notice in particular that his calcium is 14, quite high. His creatinine is 2.9, quite high. And I start to say to myself, this does not seem good for Mr. M. I get a quick CBC and his hemoglobin is 9. And I say, oh, sugar, you have that cluster of symptoms that we love because they have a great acronym in myeloma, the CREB criterion, right? Okay. He's got an elevated calcium. He's got renal dysfunction. He's got an anemia, and he clearly has some bone issues, right? I don't even have to image them to know that we got some problems going on here. So our myeloma patients, right? It's a sort of spectrum, if you will, of blood cancers characterized by the abnormal proliferation of those antibody secreting plasma cells. It's we call it this spectrum because you can sort of have some of those initial precursors and progress all the way to myeloma or not, right? Kind of depends on the patient. And again, some of those genetic markers. So we will see it again start to develop with that classic CRAB criteria, sometimes also recurrent infections as well due to a poorly functioning immune system for these guys. For our diagnostic testing, we do quite a bit for these myeloma patients. We just need some information about exactly what kind of myeloma they have, just like with our lymphomas. So serum free light chains, serum immunoglobulins, SPEP, UPEP, beta 2, bone marrow biopsy, and PET CT. Okay. So just in the interest of time, I will not go over what all these acronyms mean, but I am happy to share them with you afterwards if you would like. But I do want to talk a little bit about sort of how these mutations help identify where in the spectrum of myeloma we are. I know that this is really busy and I'm not intending to overwhelm anyone here, but simply to kind of show how these different genetic mutations along the plasma cell's development contribute to the different stages on the spectrum from MDUS, right, our sort of precursor to myeloma all the way to myeloma. And as you can see, there are certain mutations that will predispose you to progress versus not. And again, this is where it's really important for us to know about those genetic markers at sort of a deeper level so that we can target our therapy for these patients. And again, I have another overwhelming slide. Please brace yourselves. The only reason that I love this slide is because I think it's awesome, right? This slide is cool because it shows us how many options there are for myeloma patients. Oh my gosh, it's like mind blowing, right? I at least I think so. So it literally, this slide breaks down for you all the possible combinations of current therapy, although it does not have the latest and greatest bites. I'm sorry, teclistamab, but we have quite a few in here that are options for us. And we can always try something new. That's the beautiful part about myeloma. There's always something new and there's new stuff coming out. And so we can just offer you more and more and more. It's pretty great. The backbone of all this is going to be our triplet therapy, right? It's going to combine our proteasome inhibitors with our immunomodulatory drugs with our steroids. So as long as we kind of get some combination of that, or some of our monoclonal antibodies, then we can start to find hopefully good response for our patients and mix it up and show them new things, if they relapse. So I think that this, although I know overwhelming, is just a really cool way to kind of capture all the possibilities that we have for these patients. So in summary, review of systems, physical exam, 2 of the greatest tools in our diagnosis toolbox, right? They are going to give us the clues we need above the surface to think about what's happening below the surface and what other information we might need. That diagnostic testing is going to depend on what we are looking for, right? Am I thinking more of an ALL patient? Am I thinking more of a lymphoma patient, right? That's going to set me on two very different paths here. So again, important to kind of put those parts together and think about how I want to diagnose and treat my patient. All of the ongoing advancements that we have in targeted therapy are for those very specific genetic mutations. So it's really important that we get the diagnosis right and right from the beginning. So, you know, sometimes I know it can be overwhelming and frustrating for patients because they're like, I just want to treat this. And we'll say, yes, we do too, but we want to treat it right. That's going to improve your outcomes overall. So again, important for us to put all those pieces together so that we get the right picture for the patient and give them the right treatment. So that's what I got. Thanks, guys. Appreciate it.